So here's what we're going to do for those that just joined. We're going to repeat the first few introductory slides for signal interpretation. I'll go a little bit quicker this time, and then we're going to jump right into UroVysion. This is approximately 45 minutes, and we'll do, again at the end, the last 15 minutes, we'll open it up after about 35 or 40 minutes for questions, and then we'll have an overview of the Neo tech-only FISH. The FISH signal interpretations. When we talk about signal interpretations, we're talking about basically only 5 different kinds of signals to interpret in all of the probes that are out there. For UroVysion, we're going to be focusing on the multicolor. In this case, we talked a little bit with the HER2 module on the dual color. We'll talk more on single color, and we showed an example, and I'll show you another example in a minute. But we're going to be focused mostly on counting spots, spot count assay, multiple color. This slide is similar to the slide that we showed in the first module, and it is a metaphase spread as well as an interphase nuclei. The purpose of this slide is to show you that whatever we do with our interphase nuclei and that you're going to be analyzing or looking at, it reflects the actual gene and location on a metaphase spread. So we reverse map these probes when we first obtain them from the molecular diagnostics company. We reverse map them onto a metaphase spread. And in this case, this happens to be one of the 6 genes for the CLL panel and a control that we add to it. And we can see that the control probe goes to where it's supposed to, and the ATM gene goes to where it's supposed to in proximity halfway between the green control and the centromere. We put this up there so that you can be comfortable that when we say 2R, 2G is normal, it's normal because we have mapped the genes, and in some cases even a control probe, to a control metaphase. To introduce you to your tech-only FISH manual, if you can turn to page 4 on the tech-only FISH manual, under FISH analysis MDS, you can see that the 4 chromosomes that are identified in MDS are listed in the first column. The location and the gene are in the next columns. You can see that for chromosome 20, as you see here, red is the color of the probe, 2 red. It's a spot count. 2R or 2 red is the normal, and in the next pattern, in the next column is the abnormal pattern. In this case, for this chromosome 20 probe, we're looking for deletion, or the absence of one of these 2 red signals, 1R. It identifies a deletion 20, and the cutoff column, which is perhaps the most important column, is the number where you need to see that many abnormal cells at or above the mean. A typical FISH analysis is 200 cells for heme FISH, which means that a minimum of 15 of these cells would need to be abnormal for you to consider this case abnormal. 15 out of 200 is 7.5%, and 7.5% is greater than the cutoff of 7.2%. So that's how we use this chart. One other example, in this case, we're looking at the 5 probe. Same thing for the MDS panel. If you move your eyes up a little bit, you'll see that it is 2 red and 2 green if you go to the normal pattern or the normal pattern column. It's a straightforward spot count. There are 2 abnormal patterns for this probe. 1R2G, which is the loss of one of the red probes, or 1R1G, which is a loss of both a red and a green probe. If you go back to the loci column, you can see that the red probe is your Q33 to Q34 gene, and that is the gene that is located in the critical region of the classic 5q- syndrome that we see associated with 15 to 20% of MDS patients. Monosomy 5 is what we see represented on the right-hand picture, 1 red, 1 green, meaning 1 red and 1 green are missing. The cutoff is 3.1%, which means out of 200 cells, we would need to see how many abnormal cells to count this as abnormal. 7. 7 out of 200 cells would give us 3.5% cutoff. 3.5% is above the cutoff of 3.1, and therefore this would be abnormal if we saw at least 7 cells that look like this. Again, that's how you use your chart. It's straightforward in terms of the probes, the location, the color, and the assay type. Okay, let's talk about UroVysion. If you turn to page 7, you can see that on your FISH probe list, at the top of that column, there's UroVysion and there's PathVysion. We just talked about PathVysion in the first module. UroVysion has 4 chromosome components very similar to the MDS panel. In this case, it's chromosomes 3, 7, 17, and 9. Here's an illustration of a classic normal cell. Normal for this particular FISH probe set, if you follow all the way across to the assay type and to the normal pattern, you'll see that normal is 2 red, 2 green, 2 aqua or blue, and 2 yellow or gold. The literature doesn't really distinguish between blue and aqua and yellow and gold, and I will most likely use those terms interchangeably, but they refer to blue and aqua is the centromere 17 probe, and yellow or gold is the 9p21 locus. Let's go back and drill down on these a little bit farther. You can see that the first 3 are centromere probes, similar to the centromere probe that we saw with HER2/neu that was relatively large. These are relatively large compared to a unique sequence probe. This probe is similar to the retinoblastoma or RB1 gene or P53 gene. In this case, it is located at 9p21, but if you look across to the next column in your chart on page 7, you can see that it's the P16 gene. So it's the P16 gene located at 9p21. It is yellow or gold, and normal is 2222. Now let's drill down on this a little bit more, because these signals don't all look the same. Don't forget, this is a 2-dimensional representation of a 3-dimensional image. We have 2 red, 2 green, 2 blue or aqua, and 2 yellow or gold. In this case, this particular interphase nuclei happens to be just entering the phase prior to mitosis. We would call it G2M, or G2, the last phase, MEM for mitosis. What we see is not only a synthesis of the DNA in the S phase of interphase, but then a replication of the DNA just prior to cell division. We see in the FISH signals what's called a doublet, and these are normal doublets. They're still connected, so that is still one signal. And there's a doublet, and there's a good doublet, and there's probably a doublet, and there's probably a doublet. This does not look like a doublet, nor does this, but it is. Why? Because it's a 3-dimensional nuclei. The other part of that doublet is below the surface. This is either the north or the south pole, and so is this. It's still normal. I'm not sure if you can see this very well on your screen, but this is probably, this little crescent shape is just some kind of a refraction or reflection. So is this down here. They're not large enough or punctate enough or bright enough to be signals. So what we're looking at is 2 red, 2 green, 2 blue, and 2 yellow. Normal. And that's what you would expect to find under your normal pattern seen on your chart on page 7. What is abnormal? This is an example of a FISH positive result for at least one cell. An abnormality is defined as extra or additional copies. The condition is considered aneuploidy. Extra or additional copies of 2 of these 3 centromeres. That's the minimum criteria. Again, this one has a little bit of nuance to it. It is FDA approved, and it does have the associated complexity, if you will, of an FDA approved scoring criteria or procedure. We need to see at least 1 extra green and or 1 extra red and or 1 extra blue or aqua. In other words, if 8 is the norm, we need to see at least 10 spots, because 10 spots would mean that you had at least 1 extra of these 3, 2 of these 3. Now, as you see from this illustration, sometimes we see more than 1 extra spot. That's the minimum criteria to call it aneuploid or abnormal. What we're seeing here is if we look at the spectrum red signal from chromosome 3, it's normal. There are 2 red signals. If we look at the green signal from chromosome 7, we can see that it's abnormal. 1, 2, 3, 4, 5, 6 green signals. If we look at the blue or aqua signal from chromosome 17, we can see that it's abnormal. 1, 2, 3, 4, 5, 6. 6 signals for blue, or aqua, 6 signals for green. Even though the red is normal, it meets the definition that 2 of these 3 centromeres are present in at least 1 extra copy, and this is considered FISH positive. 99% of your UroVision abnormalities are going to be this type of an abnormality, and that's going to be aneuploidy, extra copy. So when you look at the cell, the first thing you're going to want to do is count the number of spots. If it's 8 and there are 4 different colors, it's completely normal. If it's 10 or more, it's most likely aneuploidy. And if it's less than 8, and we'll talk about the deletion on the gold signal in a minute, that it is an abnormality involving the unique sequence, or 9p21 loci. Here's an example of an abnormal or aneuploid cell. In this case, I see 1 gold signal. Well, 1 gold signal is not an abnormality. We need to see both of them missing before we get concerned that it's an abnormal cell. We see 2 normal red signals, but we see multiple blue, 1, 2, 3, 4, 5, 6, and we see 4 green signals. That's probably a blue tucked behind that green signal. So we have 5 or 6 blues or aquas, and we've got 4 greens. This is a classic example of an aneuploid, and the FDA scoring criteria says that if you see 4 out of your total number of cells for this analysis that are abnormal like this, then the case is abnormal, and it can be scored as a positive. The total number of cells for HER2/neu or PathVision was 20. From 2 different areas. That was that FDA's scoring criteria. The total number of cells that need to be counted for an FDA-approved UroVision is 25. So if we see 4 out of 25 cells that exhibit aneuploidy, the case is considered abnormal. There is one caveat, and that is we can't stop at 25. The FDA requires that we scan the entire spot that we put on the slide. So if you spot a thin prep slide with a 22 to 24 millimeter diameter, you're going to be doing a lot of scanning. We have gotten that spot down from 24 millimeters to 18 millimeters to 12 millimeters. So we try to enrich the area, and more likely than not, you're going to see more than 1 cell in a photograph, even though these specimens are for the most part hypocellular. And so you might not see all 4 abnormalities in 1 tile or in 1 picture, but you will see some. So even if we get to 25, we need to keep scanning, and we need to scan the entire 12 millimeter circle of cells that we have dropped on that slide. And so you may see 30 or 50 or 70 or even 100 cells that we've counted, because again, FDA scoring criteria requires that we scan everything that's on that slide and not just stop after 25, even if we've got 4, 5, or 6 abnormal cells already. So the N is never going to be the same, but the criteria for abnormality is consistent. 4 out of a minimum of 25 cells that are aneuploid, and it's considered abnormal. The other abnormality is this. It's loss of the gold or yellow signals. In this case, you know almost immediately when you look at the cell. Instead of counting to 8, there's only 6 signals. And in this case, we can see 2 red, 2 green, and 2 aqua. So you can see that the golds are deleted. It's called a homozygous deletion. In the literature, in some articles, you'll see a double homozygous deletion, which is really a redundant term, but we see that in the literature. Double deletion or homozygous deletion or double homozygous deletion. And both gold signals are deleted. In the last example, we saw 1 gold signal deleted. If we see 1 gold signal deleted, it doesn't mean anything. Like the previous example, it may be that 1 gold signal is on top of the other, and there really are 2. We're only seeing 1. They both have to be abnormal. They both have to be deleted for the cell to be considered abnormal. Now, the caveat to this is, again, minimum of 25 cells need to be counted, but a minimum of 12 cells need to show the homozygous deletion for you to call the case abnormal. So 4 out of 25, a minimum of 4 out of 25 need to be aneuploid, and a minimum of 12 out of 25 need to be double homozygous deletion for you to call the case abnormal. On rare cases, you might actually see both abnormalities. you'll see both gold signals gone, and you'll see extra copies or aneuploidy. Now, what percent do we see these? 99% of the abnormalities are going to look like this. So 99% of your abnormals are going to be aneuploid, and only 1% of your abnormals are going to be double homozygous deletion. Again, they're both relatively straightforward and easy. In review, what is a UroVision positive? Greater than or equal to 4 cells with gains of greater than or equal to 2 chromosomes. It's possible all 3 may be present in extra copies. In this case, it looks like that's not the case. 1, 2, maybe 3, 4 red. 1, 2, 3, 4 green. 1, 2, 3, 4 green. Maybe 5 green. And I only see 1 blue, and I see no gold. So this probably has the gold deletion, and maybe one of the blues is gone or one of the aquas is gone, but you've got 2 of your 3 centromeres that are present in extra copies. And or the homozygous deletion for the gold probe in greater than or equal to 12 cells. That is summarized on your chart on page 7. 4 or more cells with gains in 2 or more chromosomes in the same cell, or 12 or more cells with 0 9p21 yellow signals present. And that's really it when you talk about analyzing for UroVision. Now, we do not do these under the microscope anymore with genetic or FISH technologists. 100% of our UroVisions are done on an automated instrument. There are very, very sophisticated, what we crudely call FISH spot counters. They're called FISH image analysis systems. Their first generation was in late 2001, early 2002, and since then they've evolved. We were part of a beta test for the second generation FISH spot counters. The company that makes the ones that we bought are up in New Haven, Connecticut at the Yale Biotech Park. They're called Iconisys. We did 1,000 cases, test cases with them, and the last 500 were submitted for FDA approval, and they got FDA approval. The concordance with the human eye for the last 500 cases was 100%. So we are 100% convinced that these spot counters don't miss anything with regard to UroVision. How come? Well, it's relatively straightforward for the UroVisions. A little bit harder for the HER2/neu, and for the HER2/neu and the heme fish, we're still doing a combination of spot counting with a robotic microscope and human, genetic technologists on a manual microscope. But for UroVisions, they're relatively straightforward. We're looking at here a DAPI counterstain, so only the chromatin or DNA is stained, and you can see that the normal underlying cells are small, round, and shiny. The abnormal cells are much larger and much more pale. And so, although it's very rare that you will see all 4 abnormal cells, or a minimum of 4, which is required, in one photograph, you may on occasion, and here's one of them. As an example, once the technologist, or in this case the instrument, locks on to these, we then add single band filters. And in this photograph, we only took a picture of a red and a green filter. So you'll see no aqua and you'll see no gold signals, because the point I was trying to make was that here's your abnormals. They're very easy to identify based on their morphologic characteristics under the microscope, whether you're a technologist looking at this. And again, the scoring criteria is you scan under DAPI, you identify the abnormal cells, and then you look at those abnormal cells for the presence or absence of extra signals. And in this case, we can see that 1, 2, 3, 4, 6, 2, 4, 6, 8 red, and 6 green. So whether the blue or the aqua and the gold were normal or not, this case is abnormal. And you can see that indeed 1, 2, 3, 4, and probably 5 cells were abnormal. This case is already abnormal, assuming you can get a total of 25 cells. Assuming you can get a total of 25 cells. So that's why we're very comfortable. And UroVision is our highest volume FISH test. We do no less than 300 of these a month, and on a busy month we may do 500 or 600 of these. Every single one, again, on the robotic or automated spot counters. And again, we're very comfortable that the concordance with the human eye is 100%. This is the FDA requirements, or the intended uses. FDA is approved only for voided urine specimens, although we get all kinds of kidney taps, bladder washings, we see just about everything. Please note that the FDA approval is for voided urine. And it is as an aid for monitoring for recurrence. The original FDA claim in 2003 was to look for recurrence of patients that have been previously diagnosed with bladder cancer. And in 2005, a second FDA claim was added, and that is for the initial diagnosis of bladder cancer with hematuria. In small print, it does say this is not a screening procedure. It's a genetic diagnostic test, and so hematuria should most likely, or should probably not be microhematuria, and there should be in combination with either atypia or a history of smoking, but it's clearly defined in the literature and in the FDA insert. What we're seeing is, since 2005, a tremendous uptick of the use of this test, and we're really seeing it used as a screening procedure. I mean, it is what it is. It's a very powerful genetic test. The problem is, if it's abnormal and there's only hematuria, then more likely than not, the clinician is not going to see morphologic change with cystoscopy, and they're going to be in a dilemma. And that dilemma has really been responsible for some of the lack of adoption of this technique, because this is one of the few genetic tests where we see genetic change before morphologic change. It does happen on occasion with the heme fish, but rarely, very rarely. It does happen more often with this, especially if you're not monitoring for reoccurrence, but especially if you're only looking for hematuria, or you're only doing it because of a diagnosis of hematuria. And so the literature calls those anticipatory positives. Although there are rare exceptions, the reality is cancer is coming, and it's just a matter of when. And what can the clinician do? They can continue to monitor. If the patient was coming in every year, bring them in every 6 months. If the patient was coming in every 6 months, bring them in every 3 months, etc. And so they need to be able to monitor those patients on a relatively consistent basis, because we've been able to identify that there is malignancy. There are abnormal aneuploid or deletion, homozygous deletion cells, and it's just a matter of time before morphologically the clinician is going to be able to see. All right, if you turn to page 58 in your tech-only fish manual, let's take a look at a couple of more examples. Now, on page 58, these are not pretty, this one in particular, but if you count it up right away, you can see that there are 8 signals. Despite the fact that the 2 signals on the right-hand side of this interface nuclei are more whitish, those are your gold signals. And despite the fact that the signals on the left-hand side of your interface, of this interface nuclei, are not very greenish, they're probably the green signals. Your blues are in the middle, or aquas, and your reds are in the middle and then up at 1 or 2 o'clock. This is a typical normal. I put it in your text, or in your tech-only manual, because it's not pretty. And you're not always going to see publication quality prints or photographs. But again, your clue that it's normal is that there are 8 signals. And if you can identify 4 different colors, even if they're not beautiful gold and beautiful blue and beautiful green and beautiful red, more likely than not, it's a normal interface nuclei. If you turn to page 59, you'll see a typical example of an abnormal. 99% of your abnormals are going to be aneuploidy, greater than 2 signals or 2 copies for at least 2 of the 3 centromeres. Can I ask, how many red signals are in this interface nuclei? 4, correct. The one at 12 o'clock is a split signal, and it's not 2, it's 1. How many blue signals are in this interface nuclei? 3. Or 2. This is a tough call. The rule of thumb, and although we didn't talk about it at the beginning of the UroVision, the rule of thumb is, if you cannot put a pencil or a pen between the 2 signals, more likely than not it's just a split signal and it's 1. The other rule of thumb, and it's more empiric than scientific, is that if you add up the 2 pieces, if you will, of a signal, and they are less than or equal to the size of the other signal, then it's probably still 1 signal. So although it looks like 3, I would probably call this one 2 based on the pencil rule, If you put a pencil on either your photograph or on your screen of your computer or up on the wall, if you're projecting it, it's probably going to cover both of those signals. And if you add up the two pieces, they're still less than or equal to the size of the other aqua or blue signal. And there are 3 green signals, and there are 2 gold or yellow signals. So we've got 3 green, 4 red, 2 of the 3 centromere probes are present in at least 1 extra copy. This is abnormal and is considered one of the 4 abnormal cells. On the next page, and you can see that 6 signals inside of 1 cell, and it's a double homozygous deletion. Both gold signals are deleted. Okay, if you turn to the next page, page 61. Without even looking at the photographs and just looking at this data sheet, and this is a tech-only worksheet, and the tech-only worksheets will come with the photographs when you go onto your secure website and you call up your cases. When you log on to your secure website with your username and password, you will see folders that will say HER2/neu, UroVysion, and HemeFish. You'll click on this folder that will say UroVysion, and you will see your individual cases. We can identify those cases by name, number, or both. And the number can be our number, your medical record number, whatever number you want it to be, and or the patient name. And then you'll click on that. And when you click on that patient folder, you'll be presented with a data sheet in the form of a PDF and photographs. The data sheet is what this will look like, and that's an example on page 61. And so you can look at that data sheet, and here's how you interpret it. In the left-hand box is always the probe set that's utilized. In the middle box, with the exception of HER2/neu, in which case we put the means, the middle box are always the normals. We don't identify it as normal because you have to know that. We cannot point you in the direction of a diagnosis. We're only doing the technical, but you need to know by virtue of this training that the middle box, or by virtue of the literature and your understanding as a pathologist of UroVision, that 2222 is normal. Plus you can look back on page 7 and you can see what the normal pattern is for UroVision. And then the right-hand box, with the exception of HER2, which are always the total number of cells counted, the right-hand box is your abnormal cells. In this case, aneuploidy of 2 or more centromeric probes, and or double deletion of the 9p21 loci. So, based on what we just talked about, without even looking at the photographs that would accompany this, is this patient normal or abnormal? And why?
Normal.
Normal. How come?
The average is below
4. Right.
4.
That's right. Only 1 abnormal cell. And you can see that there are much more, and you know this is not a QNS because this is much more than 25 cells. There were actually 57 cells that were counted or scored. Again, another clue that it's done on an instrument and not by a tech is that it will say score or instrument versus tech 1 or tech 2 or both. So 56 cells were scored as normal on this analysis. 1 was scored as abnormal. You know that you had to have at least 4 to count the aneuploidy as abnormal. This case is scored as normal. You already know it's normal without even looking at the tiles. Again, some pathologists will prefer to look at the photographs and let the photographs talk to them. Other pathologists will prefer to just look at the data and let the data answer their questions, and then confirm by looking at the photographs. Next page, another tech-only worksheet from a different UroVision analysis. Without looking at the photographs accompanying this, is this normal or abnormal?
Abnormal.
It's abnormal. Okay, you guys, that's it. In this case, 90 cells were counted. 90 cells. That's, again, if we weren't doing this manually, this would have taken the technologist 3 or 4 times the typical amount of time. It's abnormal, and why is it abnormal?
10%.
10% of the cells, exactly. Well, 7. 7 more than 4. So 7 were aneuploidy for 2 or more centromeric probes. The homozygous deletion, there were 2 cells that were abnormal, but you need to see a minimum of how many to call the homozygous abnormal?
12.
12. You need to see a minimum of 12 cells. So although the homozygous is not scored as abnormal, the abnormality is aneuploidy because 7 is greater than 4. And so of a total of 90 cells, 7 were abnormal. Okay.